Welcome to the second episode of Contagious Conversations from the Pomegranate Studios. This series has been developed by members of the Australasian Society for Infectious Diseases to explore evolving evidence, practical knowledge and real-world challenges in this field. I'm Mick Cavazzini, but I'm going to hand you over to Associate Professor Sanjaya Senanayake, who directs the Department of Infectious Diseases at Canberra Hospital and lectures at the Australian National University. Dr. Senanayake and his guests discussed the immense progress that has been made over 3 decades in the management of HIV. Once a fatal diagnosis, the disease can now be completely controlled by anti-retroviral therapy. Access to prophylactic treatment has also made a huge impact on rates of transmission in the community, although barriers remain to equitable access. And despite the remarkable control we can have over viral load, HIV is still a tricky pathogen, and the prospect of a cure or even a vaccine remain elusive.
Welcome everyone for our second podcast. Last time we talked about vaccination. Today we're talking about HIV. And we've got 3 wonderful guests who are joining us today. First of all, let me introduce Professor Sharon Lewin, AO, who is a virologist and infectious diseases physician with a hugely impactful research output. And Sharon, you're the inaugural director of a couple of very important Australian institutions. Can you tell us more?
Thanks so much, Sanjaya, and great to be here. Yes, I'm director of the Doherty Institute. The Doherty Institute's now 12 years old, a joint venture of the University of Melbourne and Royal Melbourne Hospital. But a more recent appointment is I also am the director of the Cumming Global Centre for Pandemic Therapeutics, which launched in response to the pandemic.
Thank you, Sharon. Professor Adeeba Kamarulzaman is President and Pro-Vice-Chancellor of Monash University, Malaysia, and also established Malaysia's Centre of Excellence for Research in AIDS. Adeeba, what else should we know about your background?
Well, I'm an HIV physician, and like Sharon, we both graduated from Monash University and trained at the beloved Fairfield Infectious Diseases Hospital.
Know it well, yeah. It lives in the memories of many infectious diseases physicians. And many of my colleagues who I've worked with in Canberra were there as well.
And we're both past presidents of the International AIDS Society.
Wonderful, wonderful. And Richard Keane is the CEO of Living Positive Victoria, a not-for-profit which advocates for the rights and well-being of people with HIV. And Richard, how long have you been in that role for?
So I've currently been in the CEO role for 8 years. I was diagnosed with HIV when I was 19 years of age, way back in 1989. So I've kind of seen the progress, the advancements and a whole range of other impacts across the HIV response.
Thanks, Richard. And before we get into the nitty-gritty, I thought maybe a bit of reflection on where we were in the past and to where we are now. And I remember as a registrar, one of the microbiologists I was working with attended in the 1980s one of the American conferences, I think it was IDSA or the American Society for Microbiology, where they presented this case series of a few young men who got a very unusual pneumonia, pneumocystis pneumonia, and some of them died. And at that time, it was a real puzzle. And of course, that was the first inkling of the HIV epidemic that began. And when I started training, those consultants I was training with, they'd been there at the start of HIV some 10 years earlier, and they used to talk about hospital beds full of patients with AIDS with various malignancies, opportunistic infections, and they'd be there for weeks to months, and they'd live or gradually die. And then you fast forward to now where we've got over 30 anti-retrovirals, and most HIV cases in Australia are treated in outpatients, just like a GP visit. So for me, it's astounding where we've come from. Sharon, what are your reflections?
Actually, it's interesting, Sanjay, almost identical to you. I graduated from medicine in 1986, and And HIV wasn't really on my radar then, but I did spend a year working in Kenya in 1989. And that's when I became much more aware of what was happening in HIV globally. And at that time, and in the subsequent decade after that, until anti-retrovirals came along in the mid-90s for us and the early 2000s in Africa, you know, the impact on society was just enormous in Africa, with, you know, funerals every day, enormous stigma associated with the infection. And similarly, by the time I started doing my infectious disease training in the early 90s, the first part of my training were young men dying on the wards, and then the second part of my training was everyone was on antivirals. I moved to New York in the mid-90s at the very beginning of antiviral therapy, when people actually thought antiviral therapy might even cure HIV. Of course, it can't. And we're talking about treatment advances. The other really incredible advances is around prevention, and that's a whole other new story.
Yeah. Thank you. Thanks, Sharon. Adeeba, what comes to mind for you?
Yeah, similar to yours and Sharon's, until I returned to Malaysia, where the treatment access was a little bit behind, and one of the starkest memories is, I guess, when at the time it was called HART, right? That when protease inhibitors came online, and it was literally a matter of life and death for people who could afford treatment in Malaysia at 2,800 ringgit a month versus those who didn't. So part of our early advocacy was in trying to bring affordable anti-retroviral therapy to the country, and, you know, worked with Ministry of Health and others to invoke compulsory licensing to allow generics. And then the other side of it, of course, I trained in Australia and didn't see anyone at Fairfield or any of the other hospitals I worked at who acquired HIV as a result of injecting drug use, whereas every single patient almost that I saw in the wards in Malaysia had acquired HIV through sharing of needles and other paraphernalia. And that was what got me kind of interested to do something about that, and my involvement in harm reduction and public health in general, while still doing the clinical work. Yeah.
Yeah. And I think what you also highlight with that story is that while we have to think globally about HIV, there are variations in terms of case numbers, availability of and access to treatment in different parts of the world. And Richard, what about your thoughts?
I think I come from a community impact kind of point of view. And when I was diagnosed in 1989, I came out into an environment where there was overwhelming sense of grief and loss that was both community-wide but also intensely personal. But the other things that I found there was a community that I connected to, and everyone rolled their sleeves up. I joined care teams, went into home care and support for people. I lost a partner when I was 23 myself, who I absolutely adored, and those personal initial impacts were quite staggering. But I also had this kind of endeavour to put my body on the line and go into early treatment trials wherever they were accessible here in the country. I was relatively young and relatively healthy compared to some of my peers, so I took every opportunity I could to explore options to advance treatment and connection to HIV treatments and services.
Yeah. And Richard, I think that example just shows with any global infection, no matter how clever we are as healthcare workers, no matter what medications are available, without that advocacy at the grassroots levels from consumers such as yourself, we cannot succeed. So, yeah, well done to you and those around you. That's fantastic. Having said we're at a relatively wonderful stage of the HIV epidemic compared to where we were, the reality is there's still a lot of HIV around. So since the pandemic started, the figures I've seen are approximately 84 million people have been infected with HIV. Some 40 million plus have died. In 2021, around 40 million people were thought to be living with HIV. That was about 7 per thousand of the global adult population aged between 15 and 49. So it's certainly still out there. And there are figures of around 14,000 new cases every day, unfortunately, most of which are in the world's poorest countries. So it's still an issue. But at the same time, Adeeba, we are talking and hear about all the time HIV elimination. Do you want to talk to me about what HIV elimination means? What does it mean practically?
I think what it means practically is until we find a cure, until we have an effective vaccine, it means that it's no longer a major public health threat like it was, before we had this effective treatment. And I guess in practical terms, enough people have been tested and know their HIV status, who then go on to treatment and have effective treatment and undetectable viral levels. And you hear about this, the 95 goals that the global HIV community talk about. So I think that is what we're aiming for when we talk about elimination as a public health threat.
Yeah, and when you say 95, that's a percentage of people who know their status, who
Correct.
have access to treatment and get viral suppression.
And have undetectable viral levels, yeah.
Yeah, that's...
Yeah, and another definition that's sometimes used of HIV elimination, what Adeeba says is completely true about all the strategies we use. But one other definition, which I think is really relevant for Australia, is a 90% reduction in new HIV infections and AIDS-related deaths since 2010. And I think why that's so interesting and relevant for Australia is because we're actually almost there in Australia. And several years ago, at least in inner Sydney, numbers of new HIV infections has really declined by that amount since 2010. Very few other places in the world are coming close to that. But I think it's one thing that we should be proud of in Australia. HIV isn't over, but really we've done well on reducing new HIV infections. I'm sure Richard can tell us lots more about that because it's so much related to the hard work of the gay community largely, who've done such a great job on education.
Yeah, and Richard, in fact, that's a great segue to you, because I did want to ask at the grassroots levels, what do you see that success and what barriers are left to getting there completely?
That's a really big question. There's a range of barriers that I think we still need to challenge, and they're structural barriers around discrimination, criminalisation of HIV, things that might create barriers for people wanting to test and find out their HIV status. We do have continued late diagnosis, particularly amongst our heterosexual population living with HIV, which presents a whole range of different challenges. When our community first heard about the goal of virtual elimination, there was almost a visceral negative response from some members of my community who felt that virtual elimination meant elimination of service delivery to positive people, of us being potentially eliminated as a focus study. So there was some work to do to walk our community through what virtual elimination means for us, and that was easy for me to do. We've always been on board with the lofty goals that we set for ourselves, and the virtual elimination of HIV would be a huge achievement for us, but for us the holy grail still sits with cure in the work that Sharon's doing to move towards cure, because we'll all still be living with HIV tomorrow, even if we reach virtual elimination. So it was a nuanced conversation that we need to have, but these lofty goals have always driven innovation, partnership and success in this country, and we're behind it 100%.
No, wonderful. And now, Richard, you touched on two things, or two words, criminalisation and discrimination of HIV. Now, living in Australia, a very sort of liberal country, people might be surprised to hear you use those terms in Australia. So are those issues here?
Those issues still remain as potential barriers for people wanting to test, with a whole range of laws that still exist on the books that are quite contradictory. In some ways, and I'll talk jurisdictionally here in Victoria, we have a set of laws that say you don't need to disclose your HIV status if you're undetectable, if you're engaged in prevention strategies like condom use and other things like that. Yet at the same time, we've got this contradiction that if somebody asks you about your HIV, that you need to disclose to them. Otherwise, you could be kind of in a challenging legal space for that person to say, I wouldn't have engaged in sex with you if I had have known you were living with HIV. So we've got this kind of contradictory thing. Living Positive Victoria and myself continue to support our state government's health response. So we have a health response for managing risk in Victoria that has a range of interventions that engage with problematic behaviours, lack of adherence, a whole range of other challenges that somebody living with HIV may face. And we kind of prefer that model. That still leaves the door open for a criminal prosecution if all of those other efforts and standards have not been met. But that sits with the Chief Health Officer rather than a criminal response by police.
Wow, they're completely contradictory, aren't they, those two laws? So it must be very confusing.
And particularly for those folks who have migrated here, who English isn't their first language, we spend a lot of time developing plain language resources, assisting people through engagement with our peer navigation program. So there's a genuine understanding about what their rights and responsibilities are once they receive a HIV diagnosis. And it's important to take that responsibility on. As a HIV positive person, by engaging in effective treatment and adhering and protecting ourselves, we're also protecting others.
If I may jump in here, Sanjaya, I think, much as they've affected Australians and particularly migrants, these two issues, stigma and criminalisation, are huge in countries around Australia, including Malaysia, Indonesia, Philippines, every country in the region, right? And what we're witnessing at the moment are at least two major HIV surges, if you like, crises in the Philippines and Fiji, and a lot, and Papua New Guinea and Indonesia as well. And a lot of what's underpinning that criminalization, stigma, and it's all interrelated, right? In the case of the Philippines, it's around chemsex and possibly some are even relating it to the previous war on drugs, and in Fiji it certainly is injecting drug use in the absence of injecting methamphetamine, to be exact, in the absence of harm reduction. So it's very, very much a problem here and now. Yeah, we're witnessing huge percentages of increase in both those countries I've just mentioned, Fiji and the Philippines.
And maybe I can just add to that amongst several African countries, there is reversal of laws around criminalisation for homosexuality, so that homosexuality, which was previously non-criminalised, has now been criminalised in countries like Uganda and elsewhere in Africa. So we can't take for granted that progressive views on behaviours will stay with us, with a shift to whether it's political or religious driven, but some worrying legal changes that are taking us back to another era for both people who inject drugs, but also gay men and sex work as well, all whom are key populations at risk of HIV.
Yeah, no, thank you, Sharon. I think as of September last year, about 65 countries had negative laws against homosexuality. But I should also add, in the context of this conversation, that most cases, new cases of HIV in the world today, are through heterosexual transmission. And Richard did touch on the fact that there are some populations who are difficult to reach, and heterosexual populations are one of them, maybe because of that stigma, because of the earlier associations with homosexuality. And of course, there are other groups that Richard talked about, culturally and linguistically diverse groups. And not just linguistically, the cultural beliefs, etc., might guide their behaviours in terms of seeking health help, etc. And probably, I believe also in our Indigenous populations here in Australia, that can also be a challenge dealing with a positive diagnosis. Richard, do you want to comment?
It certainly is. As with other conditions, there's a disproportionate impact on First Nations folks in Australia. And location and being able to access an S100 provider in a regular way that we kind of take for granted being in a large city like Melbourne here in Victoria, it's extremely difficult. If you're in Alice Springs, that S100 provider travels down from Darwin once a month. If you're in a remote community or you're living kind of in town camps outside of Alice Springs and you miss that appointment, there's a whole range of challenges with accessing your treatment, as well as some safety issues around carrying that treatment around with you and being identified as having HIV treatment and being asked what that's for, a whole range of other things. So there's a whole range of potential cultural impacts that can impact the ability to adhere, as well as receive the messages around prevention that we kind of take for granted in our larger cities.
Yeah, no, thank you, Richard. In terms of preventing HIV, I think even in the old days when a healthcare worker got exposed to someone with HIV, they'd go into single agent anti-retroviral therapy. So the concept of pre-exposure prophylaxis was there. But now we've taken it to a whole nother level with PrEP. And I might direct this question to Sharon, with both Adeeba and Richard. Feel free to contribute as well. So what do you think of of PrEP? Has it been successful? How does it look in the long term? Do we have to make changes to it using longer acting drugs, etc.?
Yeah, well, PrEP is undoubtedly one of the great success stories of the HIV response, along with treatment and people no longer filling up wards and living normal, long, healthy lives. PrEP has totally transformed the risk to acquiring HIV. The risk to acquiring HIV is a result of two things, actually. The first is treating people who have HIV, because once their viral load reaches undetectable levels, they can no longer transmit the virus, something that we call undetectable equals untransmissible, or U equals U. Absolutely revolutionary impact on people's lives and also risks of transmission. And as Richard said, people who have an undetectable viral load can safely have sex with whoever they want. They're not going to transmit the virus. At the same time, taking an antiviral to prevent HIV is also very effective. In Australia, it's been particularly effective using what we call oral PrEP, which is a single tablet a day, taken either daily or before or after sex. And its efficacy is really high as long as you take it. Been super high here with people that are educated and have great public health support and great public health campaigns. But in some low and middle income countries, oral PrEP has not been that successful because, as an example, young women who want to keep this secret from their sexual partners just don't take it at the same frequency. And the real recent advances has been injectable PrEP, initially every 2 months, but in the last 2 years I've become aware of a incredible advance, which is giving PrEP, or a drug called lenacapavir, every 6 months with close to 100% efficacy in settings where previously oral PrEP was 25% effective. So now we have almost like a menu of prevention options for people, a lot of choice, as we have, say, with contraception. And it's very, very exciting. Where we haven't yet advanced to a product, but there have been scientific advances in developing an effective HIV vaccine. Much harder, but there's still some exciting advances there. But PrEP and U equals U are the two things that have driven infections down in a country like Australia, but also in some countries in sub-Saharan Africa. This is not just seen in high-income countries.
Yeah, and I love U equals U. I won't forget that one.
Oh, well, I need to jump in then, because I just think that that's been a revolutionary change in the way that positive people see themselves, knowing that you can't transmit your HIV onto a sexual partner means that for the first time in my experience, we started to see folks kind of accessing the healthy sexual and reproductive relationships that we thought were not possible for us, and particularly across heterosexual communities, heterosexual men and women living with HIV. They would turn up and engage with our peer navigation program after a diagnosis and think that was the end for them, that's the end of their life. 3 or 4 years later, you're going along to a social event and you'll see them there with their new husband or wife, baby on their arm, grin across their face. It has been such a huge change. And I also want to acknowledge the bipartisan approach of government in this country has also been central to the success in the rollout of not only the U equals U messaging and a whole range of other things, but shortly the removal of barriers for Medicare ineligible folks to access ARV treatment, now the same with PrEP, means that this is a key factor in us moving towards what I think is a realistic goal of virtual elimination in this country, and I'd love to see Australia get there first.
Wonderful. Thank you, Richard. Now, we talked about the wonderful success of PrEP here in Australia. Adeeba, if we go to Malaysia, what's the state of PrEP there?
After a slow start, I think we're starting to scale, although not to the extent that we'd like. But what we have, and I think we, given the conservative environment that we live in here, we do have government support. It is based on domestic funding and good partnerships with CBOs and private, also with private GP providers. So we're getting there, but not as fast as we can. And I think one other way, because although stigma has lessened somewhat, but it's still not enough. It still is there, preventing people from coming forward, from being tested, etc. So finding ways in which digital technology can not just raise awareness, but allow people to sort of access information. And even we have a program where potential patients can order their HIV test kits to do self-testing and then be linked to either PrEP or treatment. I think these are the programs that we've put in place post-pandemic that we're starting to see expand. So I'm hopeful there, but there's still a lot of work to be done to get it to scale, to really bring down the numbers. It's been plateauing at about 3,000 new cases a year, and largely within key populations that are no longer the injecting drug users from decades ago.
Yeah. And Richard mentioned the bipartisan political support we had here. Is the political landscape similar there, even though the resourcing may not be the same?
It's a little bit more tricky because, like I said, the conservative nature and government, often current ruling government and previous government that's a little bit more progressive, often have to defend themselves in Parliament, like, why are you giving free PrEP, why are you giving free treatment to this group of people, and that's where I think the success of working with civil society is really important, because civil society can kind of cushion some of that negativity. So we work very closely with government. We here, meaning I'm putting my civil society hat on.
Thank you, Adeeba.
I think it's also worth commenting that, the global landscape for access to both treatment and PrEP has dramatically changed in the last 2 years. It has not affected countries like Australia and perhaps not so much Malaysia, but the change in US administration, the dismantling of USAID, the changes in a program called PEPFAR, which is America's biggest investment in access to anti-retroviral therapy, a $6 billion a year program, the President's Emergency Relief Fund for AIDS. That has meant that many countries that had really successful programs of both treatment and prevention, but particularly prevention, no longer have access. So we should really acknowledge that globally things are not as rosy as we thought they were heading towards. Even just 2 years ago with injectable PrEP, global uptake, we've gone back significantly in many countries.
Yeah, I think add global fund to the mix, because it's not just the US government, it's government, wealthy governments around the world that are not putting their money into the global fund. I think they're short by several billion from the recent replenishment, so a huge setback.
I also have a couple of concerns about the populist politic of the day and the permission structure that's being provided to walk away from these commitments that have been engaged over a very long period of time. So we are very lucky to have the Friends of HIV network, a multi-partisan body at the federal government level, and we'll continue to work with them regardless of whether there's a change of government in the future. But all of us are a little concerned about the permission structures that are being enabled to kind of walk away from previous commitments.
Yeah. And look, I think the only infection we've ever eradicated from the world was smallpox. And the next one we came close to was polio. But then when we were sort of almost there, we've had hiccups in terms of vaccination programs, etc. So I think maybe we're not talking about eradication of HIV here, but elimination and controlling it. It's on a global scale, it's always going to be tricky. It won't necessarily be smooth running, but I guess that's my segue, talking about two vaccine-preventable diseases, about vaccines. Sharon, what's the HIV vaccine landscape like at the moment, and what are the barriers?
Yeah, developing a vaccine for HIV is tremendously difficult because no one naturally clears the virus. So when we design vaccines like for COVID, we just need to imitate a healthy immune response with our vaccine. That's been really tricky with HIV. We've got a few clues of what helps, but we don't have a natural model of clearance. So there are two major arms of the immune system that we want to boost with vaccines. One is antibodies. Everyone knows about antibodies because of COVID. And the other is T cells. Two arms of the immune system that are actually important for HIV clearance. And with an HIV vaccine, we've sort of bounced around about what's more important, T cells or antibodies. I think the big advance and I should also say, huge investment in vaccine science from largely the US government. And that's taught us so much about immunology. And actually, it taught us a lot about developing vaccines that were highly relevant for COVID, but we're not there yet. The exciting bit, and I'll talk very briefly about vaccines now, is the discovery that some people make really good antibodies naturally, and we call them broadly neutralizing antibodies, meaning that the antibodies recognize lots of different strains of HIV and can stop those viruses in their tracks. And we know how to make those broadly neutralizing antibodies in test tube models, and we're now learning about how to induce them in people. And in fact, there has been some phase 1 studies of broadly neutralizing antibody-inducing vaccines, very complicated. You need sort of 6 to 8 vaccines to get there. And people can make broadly neutralizing antibodies following vaccination. So there's a big shift focus now on trying to induce broadly neutralizing antibodies, but we're a way off getting at its scale. To do a vaccine study at scale now, you have to compare to PrEP, because you can't just randomize people to a placebo. So efficacy studies are very, very expensive. And so you need big investment here from a government like the US or big pharma to really, nail us getting a vaccine. But there is advances on the science. And I still believe we need one, because PrEP requires a lot of infrastructure around it. You've got to buy the drugs. They're not cheap, especially not the injectable ones. And you have to have an infrastructure to keep people taking them or keep delivering to them. A vaccine would be far preferable, but we're still not there.
Yeah. And I think for people who know, there'll be some people listening to this podcast who know a little bit about HIV, but not too much. And they might think that if you can get rid of levels in the blood, make it undetectable in the blood, why isn't it cured? But there are places that HIV hides, aren't there, Sharon? Do you mind briefly explaining that?
Yeah, so when you put people on treatment, as you say, the virus rapidly disappears from blood. You can no longer transmit the virus. Your immune system recovers and you can live a normal, healthy life. But the virus goes into hiding in something called latency. Many viruses have latent forms. COVID doesn't, as an example, while the glandular fever virus does. So, latency is a very nice trick of viruses to persist forever. And so we know that the virus goes into hiding in cells. Very few infected cells, maybe 1 in a million cells are infected. But as soon as you stop treatment, if you've been on treatment for 10 years or 20 years, your virus pretty much comes straight back up in 2 to 3 weeks. And so there's a lot of work now around the world trying to eliminate latent virus, or alternatively boost someone's own immune system, like trying to get people to make their own broadly neutralizing antibodies, and that will keep the virus under control once you stop antiviral therapy. And just in the last 2 to 3 years, there's been a number of clinical trials, small, phase 2 studies, ranging from 30 to 100 people, show that you can actually induce quite good immune responses in people already infected with HIV. But we're still way off a cure that would mean your virus is truly undetectable at undetectable levels. Also, some really exciting advances in gene therapy, where you can actually deliver someone a gene to make those broadly neutralizing antibodies. So we're going to see a lot of new changes, I think, in options for cure as the science gets better around immunotherapy, that lessons we learn from cancer, around gene therapy, around mRNA therapeutics. These are all technologies that will really help us solve this problem of eliminating latent virus.
Yeah, and I think while prevention is better than a cure, I'd certainly take a cure any day if we could achieve it. And you're right, gene therapy is so important. We're seeing conditions like sickle cell anemia. In the US, they're offering gene therapy, which I believe can cure it. So we're thinking about things we never considered before. So that's really wonderful. And Adeeba, maybe do you mind just briefly talking about the cures we have had for HIV and the context in which they occurred? I guess specifically the Berlin and London patients. What they were? Could you explain to our audience what they were all about?
I think that goes to Sharon as well. I think the science of it. She's the guru there. But very briefly, I think what each time when we have those patients who have been cured, and I believe it's not so simple. Especially the first few patients who were cured because they had to undergo transplantation and bone marrow stem cell transplantation and others. So the pathway to getting cure itself was not easy, but it allowed the scientific community to understand what it takes, and a lot of further research then goes into it, and I think it gives a lot of hope to a lot of people, and Richard will be able to speak better to this. So I think there are many lessons that we learn each time there is an episode of someone who's been cured from HIV. Is my big picture of it with the science. You need to throw that question back to Sharon because she's the Sifu here.
You've explained it nicely. Yeah.
I can just mention it briefly. There's been 10 people cured following stem cell transplantation globally. They've all been in high-income countries, I should say. No reports yet from low and middle-income countries. And most of them, but not all of them, received a bone marrow transplant from a donor who is naturally resistant to HIV. So there's a gene that called CCR5 that HIV needs to enter into a cell, and about 1% of people, of Caucasians, lack that gene and don't express CCR5. It's not the whole story about cure, but there's other components that led to people being cured, the donor being CCR5 negative, graft versus host disease, the preparation you have for your transplantation. But I think Adeeba is absolutely spot on about everyone gets very excited about this. There's always lots of news headlines, and we try and dampen down people saying this doesn't mean a cure for everyone, but it's incredibly inspiring for a community that it is possible, and it does give us clues. So, for example, there is a whole program of work being done to use gene therapy to knock out CCR5 rather than having to have a transplantation. So we learn a lot from this. And we also know that there's very few people that can naturally control their viruses to undetectable levels. And again, these people are very, very rare. We call them exceptional elite controllers. There's been about 5 adults described and a few more children described that have been able to do this. And again, many groups around the world are studying their immune system intensively to understand what it was that allowed these people to essentially eliminate the virus on their own.
And I think from a community perspective, I want to acknowledge all of those 10. They were probably gravely ill to undergo those treatments to begin with. Many of them are no longer with us, but they chose in that moment to trust the science, take the opportunity, put their bodies on the line in an altruistic way that I think we see represented in both small and large ways across our community. And they continue to inspire us to support the work that Sharon does in cure with treatment interruption trials and a few other things like that, where people are still passionate about doing anything that they can to move us towards that end goal of that holy grail for us, which is cure.
Yeah. Look, on that final note, I'm going to close this wonderful discussion where we've looked at HIV over the decades from a consumer, epidemiological, clinical, laboratory point of view and covered so much. And I think there's definitely more cause for optimism than pessimism, particularly with people like Adeeba, Richard and Sharon involved in HIV medicine. So thank you all for your time, and I hope we can catch up again.
Thanks so much, Sanjay.
Thank you.
Thanks, everyone. Bye.
Thank you once again to Richard Keane, Professor Adeeba Kamarulzaman and Professor Sharon Lewin for taking the time to share their expertise. And also to Associate Professor Sanjaya Senanayake for volunteering to be the able host of Contagious Conversations. Development of today's episode was also assisted by Dr. Emma Page and Dr. Sushana Krishnaswamy from ACID's Viral Hepatitis and HIV Special Interest Group. Thanks also to Inga Megget, tireless all-round coordinator at the Australasian Society for Infectious Diseases. If you'd like to get your own specialty society up in lights, please get in touch with me via the email address podcast@racp.edu.au. I'm happy to discuss what kind of input and commitment is required to get a series like this going in the new year. At our website you'll find 150 previously published episodes of Pomegranate Health. Just click on Episode Browser to filter this back catalogue by series, clinical specialty or domain of professional practice. And if you want to learn more about infectious diseases, the College Learning Series has over 30 lectures on STIs, tuberculosis, mycobacterial infections in children, and more. Just head over to elearning.racp.edu.au and check out the CLS or the Medflix library, which contains some great seminars. These include recordings from RACP's LIFT series, designed to promote learning, innovation and forward thinking. This podcast was produced on the lands of the Gadigal clan of the Eora Nation. The RACP is committed to equitable healthcare for all Aboriginal, Torres Strait Islander and Māori people. I'm Mick Cavazzini. Thanks for listening.